Okay, hello everyone. Welcome to our continuing education series in support of our military and veteran community. I am Dr. Jenny D'Olympia, the director and a faculty member of our military and veteran psychology and train vets to treat vets programs. It is my pleasure to introduce one of our military students who is part of our program development team and who will introduce our guest speaker and our program for the day. Mia Porter is a fourth-year student in William James College's clinical psychology doctoral program. She has a master's in psychology and is specializing in treating military and veteran populations. She's completed her advanced practicum training at the Bedford VA, providing mental health services for our veterans. And she completed that last year. Mia previously served in the Army National Guard for 5 years as a medical service corps officer and was awarded the Army Psychology Health Profession Scholarship, which will grant her an opportunity to ascend to active duty as a U.S. Army Behavioral Health Officer in the near future. Mia?
Hi, everyone. Jenny, can you hear me okay? My computer started to, okay.
Yep.
So I'd like to introduce our speaker today, who is Nora Drane. She is a suicide prevention coordinator at the Bedford VA Medical Center, specializing in substance use disorder. Nora has been working at the Bedford VA for 13 years. She has worked on the acute psychiatry unit, as well as the Veterans Mental Health and Addiction Program prior to joining the suicide prevention team. Prior to working at the Bedford VA, Nora worked in crisis intervention services and elder protective services. Nora has a bachelor's in clinical psychology from Tufts University and has a master's of social work from Boston University. I'd now like to take a moment to discuss why suicide risk is so important, especially among the military and veteran populations. According to the World Health Organization, almost 1 million people die by suicide every year. Suicide is the 10th leading cause of death in the country, and an important consideration is that suicides have consistently been underreported for a variety of reasons, and researchers have estimated that the suicide incidence may even be 10 to 15% higher than officially recorded for these reasons. It's also the second leading cause of death in the US military. Approximately 20 veterans die each day by suicide, and according to the Office of Suicide Prevention, veterans represent only 8.5% of the US population, yet they account for approximately 18% of all adult suicide deaths in the US. So that statistic right there really highlights how disproportionate the number of suicide deaths are among the military veteran population. So with this said, it's so imperative that we accurately assess for suicidal thoughts and behaviors, which is exactly what Nora is going to talk more about today. So I am now going to transfer it over to Nora. Thank you.
Thank you, Mia, and thank you, Jenny. And thank you all for joining with me today for this presentation on suicide risk assessment. So it's certainly my pleasure to be invited back to William James to present virtually to all of you today on such an important subject. And given that all that is going on in our current world, mental health and suicide prevention efforts to continue to be a significant need. So I do realize that the topic of suicide can be upsetting, can be triggering. So if you do need to take a break or just, take a step away from the computer for some time, please feel free to do so. I also understand that sort of talking about suicide, even with a veteran or an individual, if you're not working with veterans, just can be anxiety provoking and scary, no matter how many years you might have in the profession. I do just want to remind you that, and I think we all know this, that talking about suicide to an individual is not going to put the thought into their head and cause them to act. So having those tough conversations and being willing to engage with a individual around their suicidal crisis can be a prevention measure in and of itself. So before we get started, I just do want to let you know a little bit about what my hope is for this training. And Mia, it's fine if you want to go over onto the objectives. That's great. My hope for this training is, as I recognize there's probably a lot of experience in the room with suicide risk assessment, it's really to help you strengthen your toolbox when it comes to engaging in suicide risk assessment. So our objectives are that you will become more familiar with the suicide prevention program within VA. You'll have an understanding of the tools that we use within VA to assess suicide risk. You'll gain familiarity with the CSSRS, the Columbia, as we know it in some sectors, and the CSRE, which is our comprehensive suicide risk evaluation, as well as have a greater understanding of suicide risk stratification and overall risk assessment. You can move forward. So I would be remiss if I didn't acknowledge that September is Suicide Prevention Month. So as we gather today, I do just want to be mindful of those that we have lost to suicide and those that they have left behind. I think Mia captured fully in those statistics that she presented around the crisis that we have around suicide as a public health issue. So the VA has been doing suicide prevention work as far as programming since the early 2000s. So just a little bit of history about the program. So initially when it was implemented, there was only one suicide prevention coordinator in each of the large VA facilities. So when I joined in 2007 to the VA, there was one suicide prevention coordinator for Bedford VA. As the years have progressed and the needs have become so much more publicized and acknowledged, the suicide prevention program has grown since its implementation. So right now, just at Bedford, and we are, one of the smaller hospitals, I would say, given that Massachusetts has 3 VA facilities across our state. Our team has 3 suicide prevention coordinators. We also have administrative staff, as well as a half-time psychologist who works in our program around implementing some of our evidence-based practices for veterans with suicide risk. So the program has grown. Boston VA has a number of case managers, as well as different facilities offer peer support specialists and psychologists and nurses. So the program has really grown since its inception. So what do we do? I think that's really important that regardless of whether you work currently with the veteran population, you may encounter a veteran in whatever work you're doing. And it's really important that you have some resources that you can connect them to if you are concerned about them. So the suicide prevention team provides ongoing monitoring and support to veterans that have been assessed to be at high acute risk for suicide. Our team is in charge of implementation and removal of high risk for suicide flags that have been placed in the veterans' records, and provides clinical case management as needed to those veterans. We provide training and consultation on risk assessment tools, as well as suicide prevention interventions to our staff members and our clinicians. We work closely with the various hospital programs and services to identify any veteran that may be presenting with increased risk factors and to collaborate on their care. And we also conduct outreach events such as what we're doing today to ensure that our partners and organizations in the community are aware of the prevalence of veteran suicide, the efforts being made to decrease this, as well as how to access resources and supports that are available. We additionally respond to all local consults that have been generated by veterans in our area to the Veterans Crisis Line. So oftentimes what we do we get consulted across the hospital. We sometimes get calls that are just cold calls that somehow somebody has connected our phone number to whomever, and can you help this person connect to care? So we oftentimes are those individuals that are helping veterans or their family members get connected to resources within the VA. So before I move on, I just want to talk to you a little bit about, because you may encounter a veteran who says that they are followed by our team and that they have a flag on their chart. We have an electronic medical record that will, as you input someone, if a veteran is followed by our team, the flag comes up, and it's just to notify staff and clinicians, whomever may encounter this veteran, that they are followed by our team. They are at a higher acute risk for suicide. And the idea is that it alerts those staff and providers that if, for example, a veteran no-shows to an appointment or leaves a program abruptly, that there's additional steps that are followed beyond what would be the normal response for this type of behavior occurring. So again, it's a notification. They're not permanent. So the flags do not stay on a veteran's record forever. They are reviewed every 90 days with the veteran's clinical team in consultation with our team. That is also done when we decide to place a flag. We are not always the experts on that particular veteran's situation. So we really want to be able to engage with the providers that know the veteran to get their feedback. So again, it's not meant to be stigmatizing in any way. It's meant to alert people that this is someone that needs some further care and attention. Next slide, please. And you can go to the next one. So the VA suicide prevention program has historically focused on the intervention piece, oftentimes what we consider more downstream efforts when it comes to the intervention when a veteran is actually in the midst of a suicidal crisis. So in the past couple of years, the suicide prevention program has really moved to a public health approach and more upstream efforts around prevention to help veterans before a suicidal crisis comes up. And one of these significant upstream approaches is the VA's approach to suicide risk assessment, which in VA we refer to as VA Risk ID. So what that entails is that the VA utilizes high quality evidence-based tools and practices, ensures the fidelity of those best practices, and it outlines a clear process for who should be screened and evaluated, when the screening should occur, and how the screening should occur. The VA recognizes that each identification of suicide ideation affords the best opportunity to reduce the risk of a suicide attempt or death. It's not transdiagnostic, so these thoughts are not limited to a single medical, mental, or behavioral health diagnosis, and they affect a wide variety of the population and across different clinical settings. So you can go to the next slide, please. So what are the tools that we use? So many of you may have familiarity with the Columbia Suicide Severity Rating Scale, or the CSSRS. So we require this yearly for all veterans enrolled in VA healthcare, and what we call a clinical reminder. So an example of this is that a veteran only receives primary care health care. So they've never had a mental health diagnosis. They are still going to be screened for suicide risk at their yearly physical. This reminder will pop up, and it will ask the provider or the triage nurse to run through the CSSRS. These are also done at admission to all of our mental health programs, our CLCs or our nursing home units, our urgent care triage utilizes this. So again, the idea around this is it's a brief process to identify veterans who may be at increased risk and may need the further evaluation. The benefits of the CSSRS is that pretty much anyone can do it. You don't have to be a licensed independent practitioner. So nurses can do it. We have had our peer support specialists be able to ask these questions, again, just to get the assessment going and started. So we do have a process in place for if it is positive, that is when we do this comprehensive risk evaluation. I'm going to run through the questions for the Columbia as well as so you can at least see that. And then also for the comprehensive. So I'm just giving you a brief overview at this point of what both of these documents are. So the comprehensive risk evaluation is really the process by which a clinician gathers information to evaluate a veteran's acute and chronic risk for suicide and to develop an individualized risk mitigation strategies. So again, you're gathering information in a much more, overall picture. You're having access to the veteran's record, and it's much more of an in-depth, think of it as a more deep dive approach to suicide risk assessment. So next slide, please. So for those of you who are a little bit more visual, again, the CSSRS is really just the screening tool to detect who might be at risk. And then it would prompt you if you need a further evaluation. And then you go to the VA comprehensive suicide risk and the CSRE to inform clinical impressions about acute and chronic risk and their associated disposition. Next slide, please. So the Columbia, again, it's standardized for any provider that you can ask. It's structured. You're asking the questions in a specific order and the way they are written. They focus on an individual's wish to die, suicidal thoughts without intent or without with a specific plan and intent, and it asks about recent preparatory behavior or a suicide attempt. Next slide, please. So again, it's standardized. The VA has made it 8 questions as opposed to the original format, which was 6. And it's structured. It's identified by Joint Commission as a validated screening tool. And again, it helps you identify those veterans or patients who warrant further evaluation. Next slide, please. So again, it's a minimum of 3 questions. So again, this is not a time-consuming process. If a veteran answers no to those first 3 questions, the questioning stops. And the maximum is 8 questions. So if there is a suicidal ideation behavior reported, they're going to get the 8 questions. And then that person's going to do a warm handoff, if they're not a licensed independent provider, to a licensed independent provider. You can incorporate the CSSRS into an electronic health record. So we have it embedded in many of our templates within VA for triage assessments or for intake assessments to our different programs. It's also built to automatically skip ahead to the next indicated question based on the yes or no function of it. And at the end, it tells the person completing the assessment what's needed. So it'll literally tell you like, stop, you're all done, or it'll tell you that more evaluation is needed, and it will spell out the reasons why. Next, please. So now we're just going to take a look at the questions just so for familiarity. And again, the scoring for this, a positive screen is going to be a yes to 3, 4, 5 in the past month, and or 6 in the past 3 months. As you'll see, because that is 6 questions, the VA has 8, so you'll see it broken down individually into 8 questions. So you can just move to the next slide, please. So the first question is that wish to be dead. Over the past month, have you wished you were dead or wished you could go to sleep and not wake up? If the answer is yes, you're going to be moving to the next one. So a good example is I just want it to be over. It would be easier if I didn't wake up tomorrow. That's going to prompt the screener to then go to the next question. Next slide, please. So now we're going into suicidal thoughts. Over the past month, have you had any thoughts of killing yourself? If yes, the veteran endorses general thoughts. So again, I've considered killing myself if things don't get better. It's going to move you to the next question, which is number 3. Next slide. Now we're going to talk about method. Over the past month, have you been thinking about how you might do this? If yes, the veteran endorses thoughts of suicide and has thought of at least one method. So I thought about taking some pills, but I would never go through with it. You can go to the next slide. So the fourth question is the intent. And this is really, again, where it's important that you're asking the questions the way they are intended to be asked. Over the past month, have you had these thoughts and some intention of acting on them? I've thought about taking some pills and I'm not sure, but I might go through with it. It's very different than the person in the question 3 who said, I, have no intent to do this. Because at that point, it would have stopped. The assessment would have stopped at that level. This answer warrants further questioning. So it's going to go to question 5. Next slide, please. So plan. Over the past month, have you started to work out or worked out the details of how to kill yourself? And again, question 6 is around that intent of utilization of this plan. So do you intend to carry out the plan? I'm tired of being such a burden. I know my family would be better off if I wasn't around anymore. I was planning on driving up to the mountains this weekend with my gun. It would be a couple of days before anyone would come looking for me. Again, there's intent, there's a plan. It's going to prompt you to the next question. Next slide, please. So the preparatory behavior. So have you done anything, started to do anything, or prepared to do anything to end your life? And was this within the past 3 months? So the veteran tells you, yes, they've collected pills, obtained a gun, gave away valuables, wrote a will or suicide note, took out pills but didn't swallow any, held the gun but changed their mind, or was grabbed from their hand, went to the roof but didn't jump. All of those things that are sort of indicating that they did engage in that preparatory behavior, that is going to prompt that need for further evaluation by a licensed clinician. Next slide, please. So this is just a summary, basically, of how we went through that. The positive result, yes to questions 3, 4, 5, or 8. At that point, box is literally going to pop up in our electronic record, and it's going to tell that individual who's completing the screening that a CSRE is needed. And again, if that person that's completing the screening is not a licensed independent practitioner, they cannot complete the comprehensive. So they would have to do a warm handoff and get that done within 24 hours. So that is oftentimes much longer than it takes providers to respond. Every VA program at Bedford, we have a specific response time that's even narrower than that 24 hours. So for example, in the nursing home units, if a veteran is identified as needing that comprehensive suicide risk evaluation, the social worker literally has 4 hours to complete that. So that's just a requirement, because there's certain mitigation strategies that the nursing staff has already been alerted to that they will have to do for that veteran if they are concerned about their safety. So next slide, please. So the comprehensive risk evaluation. So again, I recognize that suicide risk evaluation is probably part of everyone's practice that's attending. The hope of this is to show you a standardized and structured format for how to assess the risk, as well as how to, documentation, or what are some of the key elements to help you to focus on. And the comprehensive suicide risk evaluation, it's a tool that was developed and recommended. And of course, typical VA is sometimes mandated by certain programs that someone's in. They're very good in our residential programs for doing the Columbia, but then at that admission, you have to do the comprehensive regardless of what the answers were to that Columbia. And sometimes that goes over really well with veterans, as you can imagine, because it's much longer. So I do recognize that the comprehensive does take a bit more time because you are gathering much more information. You're also sometimes getting collateral information, or you're doing a chart review. Ideally, you're asking a lot of these questions as you're meeting with the veteran, and it's a collaborative process. You're giving them that opportunity to, tell you about their crisis narrative. But you're also, you are able to reflect and take a look at what's going on for them from your either history and working with them, or things you sort of already know, because you are, again, part of this comprehensive suicide risk evaluation. It's right in what it is. It's comprehensive. So you're gathering as much information as you can, and then evaluating it and integrating it into more of a, your clinical judgment is coming into play to determine the level of risk and appropriate care. So next slide, please. So the elements of suicide risk, this is what we're sort of gathering. We're looking at, again, ideation. So where it's specific and direct questions around if they've had thoughts to die by suicide or any other self-directed violence. We are asking about assessment of onset, frequency, duration, and the severity. Intent. How does that willingness to act on thoughts to die by suicide and reasons for dying size up to the barriers in place preventing the individual from acting on thoughts that they are having? And we also ask for you to consider subjective suicide intent versus objective suicide intent. And again, this is where clinical judgment is key to helping with that differentiation. There are many times that we've had veterans come into our inpatient unit sort of following what is reported to be a suicide attempt, and it can be a very severe attempt. You think of overdoses that may happen, or actions that are taken when, a veteran may be under the influence of substances. And when they get to the inpatient unit and they realize it's a locked unit, they oftentimes will say, well, no, I didn't really want to kill myself. That's what they're saying now. We don't really know, but when we look at the larger picture, and maybe they have all these other risk factors and warning signs that we're aware of, or that as we get to know them, we're discovering. So we need to weigh what they're saying their intent was, as well as their objectively looking at the big picture. We're also talking to them about plans and access to means. Next slide, please. So these next slides just sort of break down the CSRE. And I know that Jenny sent a lot of materials your way, and you'll get a copy of the slides. So I'm not going to sort of go through each of these, but I do just want to let you all know that there are times when this comprehensive risk evaluation can't really be done via a clinical interview, just because of someone's cognitive ability or how they are presenting. Maybe they're under the influence at the time that you're trying to assess. But, we are very stringent on some these assessments need to be done. So we do it to the best of our ability as far as trying to get the information from the information that we know. But the VA does allow for, if you cannot do this, you have to just document the reasoning why. So again, those first questions are really around suicidal ideation, and you're asking again, about their frequency and duration and the severity. The access to lethal means, I can't stress enough how important assessing for that is. Again, it's sometimes a difficult question to bring up, but oftentimes when you're able to have the conversation and engage with the veteran about a discussion rather than you telling the veteran what to do with, for example, their firearm, if you're engaging in that conversation, a collaborative discussion of what makes sense for their situation, that can be life-saving. So you can move to the next slide, please. Again, it's, asking about preparatory behavior, When was it? What was it? Was it outpatient versus inpatient? You know, a lot of this data is tracked within VA as far as when a veteran is inpatient versus outpatient at times of attempts. So we know from the research that people that are discharged from an acute hospitalization are more at risk for suicide within a short period of time from their discharge. So the VA really wants to know about that. Next slide, please. Again, we're getting a better sense of their behavior and past attempts, when that was. And again, outpatient versus inpatient. Again, it really breaks it down. And sometimes, again, if you're working with this veteran ongoing, you may be able to have this information already at hand. But it's always good. There's always discrepancies that are reported. It's always good to get an understanding from the veteran's perspective about their suicide behavior and suicide attempts. Next slide. So the CSRE provides you with warning signs and risk factors. It gives you the examples of things to identify as, what are some warning signs? What are some risk factors? This is really helpful too, as you're engaging the veteran. You're sort of priming the pump, so to speak, for a possible intervention, such as doing a safety plan. You're asking the veteran about what are some of the warning signs that they may be experiencing. Again, it's gathering information, but sort of thinking about your risk mitigation plan. This might be a veteran that needs, a revision to their safety plan because they never talked about, how their sleep disturbance really impacted their suicidality before, or they may need a safety plan. I mean, it varies depending on the veteran and their situation. Next slide, please. So that weighing of the suicide risk factors and the warning signs, the offset to help mitigate that risk are the protective factors and reason for living. And again, the VA offers the ability to be able to click boxes and, with some examples of what are common protective factors and reasons for living for folks. But as you can see, they have another. And, their service animal may be one of the main protective factors or their reasons for living. That's not listed here. You can add it. Sense of purpose is so key for many of our veterans. So I think it's really is important for us as providers to know what are the reasons for keeping someone, focused on moving forward, as opposed to being, considered that all hope is lost. And sometimes we have to remind people or ask people about, what their reasons for living are. So again, you have to do an assessment. You have to engage in conversation. This document's not meant to be a rote checklist. So I really don't want people to take it that way. I really want people to, again, you're probably doing really great suicide risk assessments, but this is a way to help you sort of consolidate all that information. Next slide, please. And then we ask about clinical impressions and the risk mitigation plan. So we're going to talk about risk stratification here in a moment, but this is where it's asking you to determine acute risk versus chronic risk and low, intermediate, or high. And then the risk mitigation plan, again, you can collaborate with the veteran or their family. Oftentimes I'll collaborate with, other treatment providers if I might be doing this on a veteran that I'm not as familiar with. We talk about part of a risk mitigation plan. It's also dependent on the setting. So if you're working on an inpatient unit and you're, doing this assessment and you realize this person may be at much more risk, your mitigation strategy is going to look maybe different from someone that's outpatient, because you have the ability on an inpatient unit to put someone on a, a one-to-one with staff, versus if they're outpatient, you're really trying to mitigate that risk in an outpatient setting. Next slide, please. So just some tips for completing any of these assessments. It's really to be compassionate and try to be as comfortable as you can. The discomfort can really be unintentionally stigmatizing, or can really send the message that you don't want to know the real answer. You really want to incorporate your genuine caring style when asking standardized questions. You're acknowledging and thanking the veteran for being willing to be honest or open to sharing their experiences, thoughts, and behaviors about suicide. You're letting them know how important their safety is to us. You're allowing the veteran to share or vent, validating the veteran's experience and feelings, and you're demonstrating you're listening well. I mean, I oftentimes tell folks, it's that human side, it's that connection, it's that being willing to sit with someone who's really being vulnerable with you. And if we're just, don't have a lot of time, or we're like, oh, this is like another thing to do, I have to do this assessment, you can't be fully present. So as much as you can to be fully present and to, use your style to gather this information to help the veteran feel comfortable in disclosing, that's going to be key to then being able to work with them to mitigate their risk. Next slide, please. Again, you're remembering that the veteran is the expert on their experience, especially as you're interpreting the responses. So you're trying to get the information, because sometimes, as I mentioned, there could be discrepant information in the chart or from a provider who did the handoff to you. So you're trying to, again, asking the veteran for further information, and you're asking clarifying questions. You're asking it in a way that's not, accusatory or anything. It's more that you are able to, you're just trying to clarify information. You want to get the information straight. Next slide, please. So the risk stratification. And what is it and what's the point? So risk stratification, it's an ongoing process of systematically categorizing veterans' risk to die by suicide based on the observations, information obtained from the veteran, their caregivers, the medical record, which is what CPRS is, and the provider's clinical judgment. So your judgment is very key in all of this. So again, the effective risk stratification informs the appropriate therapeutic risk management intervention. So you can move to the next slide. So one of the handouts that you will receive, and it's also again in the slides, is the MyREX therapeutic risk management and risk stratification table. And MyREC is amazing at many different research and treatment modalities, especially regarding suicide prevention, but also many other mental health issues as well. But they have a component that deals specifically and works specifically with the suicide prevention program. And they really provide us with all of these tools that we utilize. So acute risk, and again, dependent on what your setting might be, the strategies to mitigate that risk may look a little differently. So acute risk, these are veterans that honestly, for the majority of high acute risk, I apologize, those are the veterans that our team follows. So they're experiencing current suicidal ideation, they have a plan, they have intent, they may have a behavior, and they have access to lethal means. So what makes someone at a high acute risk is that they're unable to maintain the safety alone. Intermediate acute risk, they have the ideation and plan to die by suicide, but they can maintain their safety independently. And then low acute risk, there's no intent to die by suicide. And if a plan for suicide is present, it's likely to be vague and without preparatory behaviors. When you actually look at the MyREC risk stratification table, they go into a little bit more of the common risk factors associated with someone that is at high risk. High acute risk, intermediate acute risk oftentimes looks very similar, I'll be honest with you. And I think one of the things I have to say is, seeking consultation when you're able to, especially when it comes to, documentation of risk level, sometimes it's really necessary. I can think of an example that I have had with a veteran just this week. And he's a veteran that I would say he sort of lives at that intermediate acute risk most of the time. He has significant psychosocial issues. He has a history of multiple attempts. He has many sort of mental health diagnoses and substance abuse symptoms. Some are diagnosed, some are not. And his family is not always super supportive of him. And he can sort of vacillate between being one of those veterans that can be at intermediate acute risk very quickly, given a slight psychosocial stressor that may to us not in any way make us pause to want to harm ourselves. But for him, it becomes, I don't want to be here anymore. And he impulsively took a bottle of pills that were left out when his mom was refilling his med cassette. And she had gotten up to go to the ladies' room, and he just took them because he had that thought and an impulsive action. So he sort of lives again at that intermediate and acute high risk status. Next slide, please. So again, responses to acute risk, high acute risk. I mean, those are typically the veterans that you're gonna want to have in a psychiatric hospitalization to maintain their safety so that they can be observed. The intermediate acute risk is outpatient management. Low acute risk, again, outpatient. You have part of, risk stratification is weighing the risk and how, the temporality of the situation may be. So people are not necessarily staying at one risk level all the time. You can move to the next slide. And then chronic risk. And this is, again, this is to help providers as they are documenting risk level. I think many of us have individuals we work with who have the history of suicidal behavior. They have a history of the thoughts. They might have a history of all of these things. And so we see them at chronic risk. We want to classify that chronic risk by high, intermediate, or low. And again, this is also on the MyREC table. You can go to the next slide. To sort of help, again, mitigating that risk. I have a veteran right now who is a chronic risk. So he has suicidal ideation at least twice a day. He has no plans. He has no intent to do it, but he deals with this on an ongoing basis. He also actively drinks, and his past attempt is via drinking himself to death. So he had a complete blackout, needed intervention by medical staff. So at that time, he was considered a high acute risk. As we have progressed in our treatment and following further treatment, he's sort of again, one of those, he vacillates between that intermediate chronic risk and high chronic risk. And one of the things that MyRec offers is a lot of good trainings where you can really dig much deeper into this risk stratification. Risk stratification in and of itself could be, a half a day training, I think. So I think it's just really important that folks understand that your clinical judgment is key and you're taking in that whole picture when working with a veteran who you're considering to be at risk for suicide. Next slide, please. So there's some considerations. You're remembering that suicidal episodes are time limited. That situations can ebb and flow. Risk factors can ebb and flow. Not, triggers happen. Something can happen in a veteran's life that can very quickly, as my veteran demonstrated this past week, it can become a suicidal crisis. I can't stress enough the fact that good assessment and weighing the protective factors and knowing resources that the veteran has in their life for their ability to cope with crisis can be really impactful. Safety plans are such a, I think, sometimes underutilized tool in suicide prevention, and we use them on our inpatient unit regardless of anyone, what the rationale is for them to come into treatment. So if they come in just for detox, they still do a safety plan. And I always do this with the veteran and arrange for time so that it can be fully comprehensive and individualized. A safety plan can look differently for me versus Jenny. So I think it's really important that if folks are interested in learning more about the safety plan, the VA offers lots of different trainings in relation to that as well. But I really think it's important that people know that this is a significant tool that you sort of have in your back pocket to work with an individual to help lessen their risk. So just the resources and references. Our team is available for consultation, or if there's any questions that come up in relation to VA. So I'll put my contact information in the chat, but I'm also mindful of time and that there might be some questions or comments that people may have. So again, I really appreciate all of you for listening to me and for being present, because we need good community partners in the VA. We cannot provide care to every veteran. And it's great to know that there's people that are invested in this work with our veteran population. So thank you.
Thanks very much, Nora. And I did put several resources in the chat box, including the MyRec website and all of their resources as well.
Great.
And so that you guys can access those. There may be a way we can save and send that list along to everyone. I'll have to figure out how to do that. But that's something that we'll try to do for everyone, because these are important resources and we hope that you have full access to all of them. But in the meantime, you can definitely access them from these links that I've shared over here in the chat. And Nora, did you want me to put your VA email in there, or do you have another one? Oh, you put it in.
I just popped it in. Yeah.
Okay, great. I had it in there. I think there was one question regarding the VA. They were asking what kind of cultural training that the VA individuals go through related to military and veteran populations. So I can't speak to what's happening at the VA. So I thought maybe if you could address that a little bit, it might be helpful.
So sort of thinking about coming in as a civilian, was that?
Yes.
Okay. So to be honest with you, we offer that to a lot of our trainees, introduction to military culture and sort of the process of, what it's like to enlist and go through, boot camp and all of that. I would say, and I'll be quite frank, I don't think the VA does a great job at really educating civilian practitioners on sort of the ins and outs. I got that training from literally talking to my vets, and I think that is something that I would love to see introduced into VA care, because it's not something that I'm familiar with. I didn't enlist, and I don't know what it's like, and I don't pretend to know what it's like. So I utilize what I learned from my veterans and what they bring to the table.
Thanks, Nora. That was, I really appreciate your frankness in that part of the discussion. And I do think that we have come a long way though from years ago in our ability to connect with our military and veteran populations. Our program at William James, the purpose of it is to train civilians and former military to work with military and veteran populations. We do offer a culture class, and we are going to be bringing that online soon, and it'll be likely available in a continuing education credit format. So it will be available online synchronously and or a combination of that and asynchronously as well. So that's something that we have integrated into our school. And this program is also something that we're working in conjunction with the VAs and the vet centers to continue to offer the community a connection to, or even just a window inside of the culture of our military and veteran populations, especially in these really difficult times that we're experiencing now. So we really sincerely appreciate you, all of you here today, and your attention to this really important topic. I'm a veteran myself, and have spent time in the field working with veterans. And so I'm very dedicated to this topic and is very close to home. So thanks so much for attending. I don't know if I'm looking to see if there are any additional questions. I think is the treatment, there's another question here, Nora, is the treatment plan different by gender?
I mean, I think the treatment plan is different regardless. I mean, I think it's very veteran specific. It's that veteran that's in front of you. So I think with the VA now, there is a much more of a push to bring female veterans into care and to make female veterans feel comfortable. And I know at Bedford, we have an amazing female veteran women's coordinator, Stephanie Coppolino, and she does so much to try to make that atmosphere at Bedford much more female friendly. So I think globally, there is a bigger push to help, female veterans, but also transgender veterans, feel comfortable in the VA. So again, I look at every treatment plan as veteran specific, that veteran that's in front of me. And I also have to say, just to speak of that military culture, we do have many, many staff that work in the VA that are veterans or still, active duty in the Guard, and we'll go and deploy. And those individuals have been a huge resource, I know, for me, in working specifically on the inpatient unit at times, because just their ability to help lead and de-escalate situations were so key. And I think I learned a lot just from that, working with them directly in that setting.
Thanks a lot, Nora, for your awesome lecture here today. I just was going to check in with Mia if she had anything else that she wanted to share? Because I didn't want to leave that out if she did.
I am all set. Thank you so much for checking in.
Okay, great. Thanks for the work you did on putting this together, Mia. And the Army's going to be lucky to get you when you're out there as a psychologist. So thank you. And again, thanks everyone for your attention to this very important topic during Suicide Awareness Month. And please, even though it's not Suicide Awareness Month next month, please continue to pay attention to this topic. And please, we'll be putting out another continuing education event each month for the duration of the academic year. So we should probably have, I don't know how many more. I should have that down, but adding in public's not a thing I do. So every month we'll have another one for an hour, and our next one will be about moral injury. And the one after that will be about substance use in the military and veteran populations. And then in December, we'll have another one that'll be about crisis leadership from one of our retired, a retired colonel who was a graduate of one of our programs. So thanks again, everyone, for your attention. Please let me know if you have any questions or reach out to Emily and she can pass them to me as well. And also, please, I think in order to get your continuing education credit, Emily, do you want to tell them how they can do that?
Yep. Within 24 hours, you'll receive an email with a link to the evaluation. And once you fill that out, you'll receive an email with a link to download your certificate. And we'll also share in that initial email links to the resources and recordings shared today.
Oh, great. Thank you. Thanks, Emily, for clearing that up. Okay,
Yes.
everyone. Thanks so much. Have a great weekend.